thank you all for joining us today. This is the third of the Spotlight sessions for this week. The Spotlight sessions came about from the Evidence for Quality Improvement project, which was a Q-sponsored project a couple of years ago, where we were trying to raise the profile and share the stories and the brilliant work taking place in improvement teams across the country. Felt there was lots of stuff going on there about individual projects, but not about how people do improvement in your teams, how we structure for improvement, how we run the processes, how we work together to deliver improvement in our various organisations. So we did a series of those. This will be added to that session. They were really popular, and I need to ask for some more for this week. In this session, we're delighted to have Helen and Paul here to talk about the work that they've been doing in Wales to create a collaborative QI community, which spans boundaries, is connected by passion and purpose. That's their words. So I'm very excited to hear about this, and I'm sure you guys are as well. So do listen out, see what tips you can take. You can pop questions into the chat box as we go along, and there should be time for questions at the end. So I'll hand over to you both, Paul and Helen.
Thank you very much. I'll apologise at the start. I do have a meeting I can't miss the start of. So I will start the introduction and the talk and hand over to Paul. I'll try and be here for the beginning of the questions, but if not, I apologise in advance. Paul and I have discussed giving a presentation today about the formation of the improvement team in our health board. So I'm a consultant physician who's worked in this health board in South Wales for 19 years. And it took me a long time to build an improvement capacity in this health board, which has expanded over that period of time. So this is a bit about the history of how hard that struggle was when we had no improvement team, and the lack perhaps of understanding about the importance of an improvement team against quality assurance. So it started out about can I have the next slide, Paul? Sorry, I forget I'm not in control here. So in about 2014, I was approached so I'd been a consultant here for about 7 years. I'd always tried to improve things and to change things. And I grew up in a family that taught me the importance of multidisciplinary working and mutual respect between team members. My parents were pharmacists, and I used to watch them as a young adult be fairly timid about approaching a GP colleague to inform them they may have made an error, prescription error. And I remember thinking, well, that's strange, because if they're worried about approaching the same person again, then it's the patient who's going to suffer, as well as the GP who's made the error and the pharmacist who didn't approach him because of the response they'd had the time before. So I was brought up to treat everybody that I work with respect, unless they just earn it, and also to work together as a team. And I think by the 2014, I'd been a consultant for 7 years, and I was getting a little bit tired of seeing one person make a form for somebody else to fill in, or a protocol that somebody else should follow, or an SOP that should be done by somebody else. And a pharmacist approached me on the ward where I was doing a ward round and said, I want to put this green sticker in the notes, and it was about drug concordance. And at the bottom of that initial sticker, which this is a revised one, was written in big red letters, this must be completed within 24 hours in line with GMC guidelines. And I said, I'm not sure people are going to fill it in. And he said, well, why not? It's part of GMC guidance. I said, well, so are the notes. How often do you see Dr. Squiggle at some unknown date and unknown time? So we decided, why don't we all just get together and talk about potential solutions to problems, albeit at the time unconsciously and competently. I hadn't done the IA course at that time with IHI, but we thought we'll all get together, we'll sit down, and it was literally for about 15, 20 minutes every couple of weeks. And we would sit in the office there on the ward, It was myself, a senior nurse, a student nurse, the juniors on my team, pharmacist, the ward clerk, the OT, and healthcare support worker. And we discussed each project in turn and said, right, what can we do about this? And what are your restrictions or challenges that the things that you have to do within your discipline that I may not understand? So that had led on, if we go to the next one, Paul, you're not going to like my animations now, are you? My team are going to be shouting at me. I can hear them going, she's got too many animations on it. So that started us to develop the new medical model. At this time, I was a social clinical director for medicine and A&E, and we were redesigning the acute medical part of the hospital. So we were separating short stay from long stay and bolstering our ambulatory services within the hospital. And it was quite a large piece of work that was really done because of what we call the South Wales Plan, where the whole of South Wales was going to be reconfigured as to where A&Es would be, where critical care would be, etc. And alongside this, I thought, well, why don't we have similar teams based on what we call the templates? So we had one template 4 and 6, and then we had wards 12 and 14 and 19 and 20 that formed little templates with the same teams working on them. So we had different multidisciplinary QI teams that formed on those and started working on projects like reducing AKI rates and BT prophylaxis and falls, which were obviously organisational directives at the time. If we go to the next one, Paul. So we were doing very small QI projects in each of these areas, ranging from trying to amalgamate the charts together when we'd looked at how much time we'd spent on ward round, looking at drug charts. And we still haven't quite got electronic prescribing in Wales, but we're very close. And AKI stickers and standardising trolleys, etc. If we go to the next one. So this has built up over time until in 2017, we had about 47 members from 11 different disciplines that were involved in different QI projects. At this time, I'm asked to be the Associate Medical Director for Quality and Safety, which was essentially predominantly assurance. And it was about relaying all of the data and statistics to Welsh Government, responding to the Welsh Risk Pool, responding to coroners' reports. And at every single meeting with the medical director who'd asked me to do that role, I would bring this out as the most important thing. Because although these projects may not have succeeded in their small QI work, you know, their ambitions to abolish AKI, for example, what it was doing is changing the culture. So the culture was changing behind me on the wards. And at around this time, I was asked when I presented at the board why I kept going with this for so long without any support, either time-wise or admin-wise. And I said, because I don't want to work in a negative environment. And I'd noticed that behind me, these teams would start communicating. We don't have ward-based medicine, but we would have somebody, a nurse from one team talking to a doctor who's on the same team by first name terms, and them being far more likely to help each other out in a clinical environment. So I was noticing that the general culture was going from a this is all rubbish point of view to, you know, we're not getting anywhere, to actually, why do we do it like this and why can't we do it like this? So it was much more positive. We go to the next one. So we used to meet regularly. We'd have meetings down in the diabetes centre, which is where we were at the time, where all of the different teams would catch up and go through their projects and where they were, not only to improve communication across the teams, but also to help to overcome some barriers. We were given, at the time, just the junior doctors were the ones who really needed the sort of certificates of contribution to QI work. We devised a symbol, which isn't as pretty as the one we have now, but it was supposed to be that golden key with QIT on it, but nobody knew what it was, because I thought it would unlock the power of the workforce. And we'd done a number of projects, as I'd said earlier, in different areas that had been successful to a certain degree. And we'd also encouraged non-physicians to present at the Royal College of Physicians meetings and have a true multidisciplinary presentation. So it also gave other people in their CV something to say that they had contributed or led on improvement work. So by 2019, I was with Paul, I think, on the Improvement Advisor course. We were doing that, I think, weren't we, Paul, in 2019? And by that stage, we'd started to use the electronic whiteboards, which were to do board rounds. We had symbols on there as visual cues. This is the acute medical unit where people would do a board round using the symbols that would, for example, turn red with intravenous antibiotics after a couple of days to get people to think about, should I need to change it to oral, and have other such markers on. So things were progressing well, but it wasn't all plain sailing. So if we go to the next one, just before that, I had got to a little bit of a crossroads because I was stepping down from the AMD post in quality and safety, and I was very honest with the medical director and the chief executive and said, you have no improvement capacity. You know, it's one thing to do quality assurance, but unless you can change it, then you may as well, you know, just churn out the reports. And I got to the point of thinking, I can't really continue to do this on my own with all of these names on a piece of paper and trying to coordinate their meetings and support them. So I thought, well, I either give up, but I didn't want to give up, or I was going to test the water. So at this stage, we've only got these medical multidisciplinary QI teams across the medical side of the hospital, not the surgical side. So I had a lot of juniors who were saying they would rotate into the surgical side of the hospital and say, well, why haven't we got anything like this here? So myself and a colleague sat outside the hospital canteen, which is where everybody goes, with that list, and we collected names for people who were interested. The problem was I ended up with 198 staff members. So I actually went home more stressed than I had when I'd gone in, thinking now I'm really in trouble because I asked all these people if they want to be involved, and they do. So if we go to the next one. So I presented the work in different forums, the Medical Leadership Forum, Royal College of Physicians, and of course to the Executive Board. And it was at this point that we had the discussions from the non-exec members about how you've kept going for so long. I'd also presented and been heard by Health Education Improvement Wales, that subsequently offered me a job that I took, which was for sessions teaching quality improvement skills. But it was the combination of all of those presentations, and then perhaps played into our hands slightly, that the Health Board came under severe criticism for the maternity crisis and tissue viability. So at that stage, I was asked, well, do you want to be the lead for innovation and QI? I said, if you've got any resource for QI at all, I'm in. So we had our initial QI team that formed, and we focused on the areas that were most important across the Health Board. And that started to change the culture. And as I say, gave us the initial sort of diving board for where we started to develop the team. So as the clinical lead for innovation and QI, then became the QI team as it is today. My vision at the beginning is that we would have ward-based multidisciplinary clusters made of all of the different disciplines. And you'll notice that includes the most important people who know everything in the hospital, and that's the porters and the healthcare support workers and the domestics. They were also in the teams. And they would feed in and out of, at the time we had in the divisions, and then in and out of the central core team with a hub and spoke model. So that was the initial vision. We go to the next one. As I said, I'd done the IA course with that dodgy looking character at the back there. I don't know what his name was, but he ended up coming into the fold with us. So as for how the team has developed from there, Paul will go through that with Rachel and the others. But I was asked, I actually had an episode last year where I left work, and I never thought that would happen to me, but I had complete burnout. And I was asked subsequently, could I go and talk to IHI, the European branch, about why healthcare professionals leave healthcare? And I thought, well, how do I talk about this to a load of healthcare professionals who are also improvement experts? So I thought, well, I'll do it in a continuous data form. So I'll do it in a run chart. And at first, I'd set out to do this about the last 29 years of my career in a sort of, a fun way of exhibiting it. But I actually went through year on year, year in, year out, and thought, why did I give it that score about my percentage work enthusiasm per year? And it was actually quite intuitive, because even times that you see there in 2011 to 2017, things were tough. My actual enthusiasm for work was okay, because we were having the engagement. We were given permission to make changes. We'd formed the new medical model. It wasn't to say we had no adversity. There certainly was, but we managed to achieve what we set out to achieve, to improve the care for the patients. You'll see my 3 sons there were dipped. That was because, and there's no good arrow on here. You'll notice even the green arrow doesn't say good, because of course percentage of work enthusiasm is not always in the same direction as life. And all 3 of my children were premature and needed some sort of support. So that's why they're dips on the work enthusiasm side. And the following this, and after COVID, which was difficult for many of us, obviously for myself, trying to build a QI team when you're on the wards constantly seeing terrible things was not easy. But what I hadn't envisaged was that my baseline had shifted to the extent that I was so much closer to burnout than I had realised. But the upward points on this are all when we have improvement capacity, because that's what drives me. And that hopefully takes us up to the point that Paul can tell us about what the improvement team has given us since that point, and how we've expanded.
Well, thanks, Helen. So yeah, and I've seen it do that a couple of times, and I really like we asked you to put the run chart in at the end, because it shows what an improvement nerd you are. You're even plotting the birth of your own children on a run chart, but it's really insightful into your journey. But also, I think one of the take homes from that is that there's only so much you can sustain on the enthusiasm of one person, and so how that's grown into a team, I think, is a big part of the story. So thanks for that. And then what I'm going to do is pick up really and talk a bit about what came in 2021, which was the sort of development of ICTM, and that was what was born out of what you created. And so I'm just going to do a little bit about that. But ICTM is just the name we've given to the improvement team within CTM. And it consists of those 3 parts: so value-based healthcare, innovation, and improvement. And I'm really going to talk about the improvement part of this. So I'm Paul Gimson. I'm the assistant director for ICTM. My background is I'm a pharmacist, and I'd worked a lot in medicine safety, and then, similar to Helen, really sort of started to grow into quality improvement roles through trying to do projects that improve medicine safety that were sustainable, and that was where I sort of discovered quality improvement as well. So a little bit about ICTM, because I know we've got a lot of people not from Wales, so I think this picture in one sums up pretty much what you need to know about CTM. So this is a picture taken from, anyone want to hazard a guess where it's from, or what the mountain's called? Okay, it's called the Bulk. Is that pronounced right, Rachel? Because I try my best. She's nodding. I'm from not from Wales originally, but I've been there for 30 years. But it's called the Bulk. So for a start, that sums up Wales. Rachel's just helpfully spelt it in the chat, because I was going to ask if anyone could spell it, because one of the first things is it's a great Welsh word because it's got no vowels in, from an English point of view, and so it's impossible for people to pronounce. But language is a big part of where we are, and language and culture is a massive part. And I think in this picture you've got some aspects of Wales. What can you see in there? You can see a bit of snow on top of a mountain. So you can see mountains. As a health board, we're made up of Cwm Taf, Merthyr Tydfil and Bridgend. And we're split up by those mountains. So I think as the crow flies, it's about 5 or 10 miles from Merthyr to where we are now. But it'll take you about an hour to drive there and back, because you've got to go all the way down the valley and back up. So geography plays a big part in how we manage our healthcare. You know, every Welsh cliche you've ever heard of in terms of mines and stuff happened around here. So it's a huge ex-mining community, and obviously hit by the problems that brings, and the benefits, because it's also has a very strong sense of community, and yeah, also on there wouldn't be a picture from Wales. There's a sheep crossing the road there, and you can't see it in there, but there's a Welsh national flag someone painted on the thing there. That's very fashionable at the moment, but a strong sense of Welsh identity as well as local culture. So I think and sorry, in that picture there, in the middle picture, if you just look closely, you can see Treorchy in the valley there, and so Treorchy is one of your, you know, it's just about as traditional mining town as you can get. It's a fairly big town, but one of our biggest, Rachel, is it, I think, but still quite small in the grand scale of things. We don't have a city on our patch, and that's beset by the problems that we all face, such as poverty and stuff, but also the benefits in terms of community and the environment in which you live. So it's a challenging patch, I would say, but a patch with lots going for it as well. And as an organisation, I don't know how that compares to some of the organisations in England. It's actually, we're one of the smaller health boards in Wales, but I still think we're a big health board in the grand scheme of things. We've got 3 acute hospitals. We're an integrated organisation, so primary care and elements of community care come onto our patch. And yeah, someone's just shouting to me the most deprived patch in Wales. Whenever there's like a top 10 of things going wrong in health, like, I don't know, teenage pregnancies or obesity or something like that, we're always right up there, not just for Britain, but often for Europe as well. So it's a tough ask. And as Helen described, in that upward trajectory to the team forming, people may remember the Cwm Taf maternity services review, that you know, these are happening more and more across Britain now. You know, we were doing it before it's fashionable, but it was in 2019, and it was obviously very, very worrying and unpleasant, and not the sort of thing that as a health board we wanted to be known for, and obviously lots of issues to address. So that's it's not saying that's why we're here, but that's the context in which we started. And also, you know, we launched towards the end of the COVID sort of crisis as well, and Helen has already been through how we started it, and so Helen was instrumental in that. And so you can see some of the early pictures there, doing QI training. Everyone remember social distancing? We're social, you know, trying to do training while also managing social distancing. But one of the first things that Helen described was this MDTQI faculty, and perhaps this is one of the key things that we're really proud of is, and we you know, even today we've just been interviewing for new members for the faculty. We secured some money that so that we could employ people to be part of our QI team while they were still part of their clinical team. So we fund them. Obviously, we fund them 1 day a week to be part of our team, but they're still working in their existing clinical team. So by doing that, we've started to create QI champions across the whole organisation, but B, making sure that they're still embedded within their team so they can bring the benefits of that QI training back to their teams. And traditionally what we do is have people in post for about a year. So that gives us time to train them up, get them confident in QI, but we also get them supporting other teams in the organisation as well. So it's a whole sort of you know, cross-fertilization, networking, building up a community across the patch. So the QI factor, I think, is one of the jewels in the crown of this whole presentation. And I won't hold on. Isn't it great in the middle of a presentation? I've just had one of those, your computer's about to restart messages. So let me just get rid of that. So we've gone through the background a bit, and I'll go into that. I'll go into this a bit more now in the presentation. But how we started really was I suppose, like many QI teams, is essentially offering team support and trying to work with teams and projects. And as time went on, and I brought this model in from another organisation I'd worked in terms of what is it we're doing and how can we define it? Because it's really difficult to explain what we offered, and we were essentially operating a bit like a consultancy. And so we broke it down into these 6 things. And anyone who's worked in QI will be familiar with this. Is this was the sort of things as a QI team we're offering. We're offering advice around methodology and data and measurements. We're broken people, and I think this is one of the under recognized aspects of an improvement team, is how you connect people with other people in the organization who have either got the same problem or have solved that problem. And that's what we've become more and more specialists in, is connecting people across the organization with people who can help them. Because in an organization with 12,000 staff, there's invariably someone who's got the skills, got the capability, and got the experience to be able to help you. And so connecting people is a big part of it. Coaching, we heard the other day about, didn't we, Andrea, at the Q event in Bath, about various approaches to improvement coaching that's being done. But that's the approach we try and take, is rather than doing stuff for them, is coaching them to come towards a solution. So we're building up our coaching expertise, and I can see Andrea Trask on the call for now in Bevan, and with them using the resources from Q, we're looking at how we can greater increase our capability of staff as not just QI practitioners but QI coaches, and so that's a big part of our future strategy. The D is the do with. So anyone who works in a QI team knows that when people say, can you help us, what they actually really mean is, can you do it for us? We try to say no to that as much as possible. We'd rather go down the coaching route, but sometimes we do end up doing it, and particularly when, as you know, it's an ask from the exec or from someone senior, we just really needed to go in, and so that will be involved. We'll go in and do some process mapping, some quality improvement work, some project management, or whatever is pertinent to that situation. Education, I'm sure most of you got something along these lines. We've got various training programs around QI, and facilitation is the last one. Often what people need is just help bringing their team together to help them with a brainstorming session, process mapping, strategy session, and we use tools like liberating structures to help us with those facilitation sessions. So that's how we've developed the offer over the years, and this is, I suppose, the consultancy part of what we do. But what we're trying to do is start to build towards a more and I'd be interested to hear, because I'm guessing people on this call will be at various stages of this journey, is moving into a focus on whole system thinking and culture change, because we can only do so much from that consultancy point of view. So how do we enable a culture of improvement? How do we build up that capability? How do we embed QI and use things like quality management systems across the patch? And I don't know if anyone's seen it, but it was a paper by Shah that talked about this right shift from the sort of granular approach to quality improvement to the more systems-based approach. And so that's the journey that we're on now, is trying to shift our organization from the left to the right. So I would say we're in the middle bit of this strategy now, in that we're still a bit granular, but we're trying to move towards that systems-based approach. And we did have a stab at a driver diagram. I suppose we wouldn't be a QI team without a driver diagram. I'm not going to go into that in detail, but we tried to break down the various bits into those things. I'll skim over this because you can have a look at it later. But the 3 pillars are the training and capability, embedding QI across care groups. So care groups is how care in this organisation is organised, and a big feature of what we want to do is embed the training and the principles and the champions within the care group teams themselves, rather than it being offered from an external group like us. And the reason I put prioritising patient safety in there, it's not that everything isn't important, it's just that as a team, we've been based in the nursing patient safety directorate, and so that's where we've tended to lean our work into. And so we're part of the patient safety team, so a lot of our QI work does tend to lend itself to patient safety. So the things that we're doing underneath that, which might be more interesting, I'll go through some of the key program areas. And by the way, if any questions come in, I'm happy to answer them as we go on at the end, but someone might have to tell me there's a question. So Simply Do. So one of the first things that was done was thinking about how can we a big part of our philosophy is about engaging all staff in QI, rather than being a team that either just listens to the exec and senior management, or that, you know, listens to ourselves. And so we purchased this platform, Simply Do, which allows us to sort of hear improvement ideas from staff and act upon them. And so we got this software, and it gives us the ability to issue various challenges out there, and then through those challenges, people can input what they think is the right idea. So, for example, we issue a challenge around winter pressures. We issued a challenge around, patient safety. What's another one, Rachel? My mind's gone back, about maternity and some of the issues around maternity. So it allows staff in those teams and across the organisation to input in a sort of non-threatening environment ideas that they think are good. And we also have an always-on challenge. So anyone at any time who's got an idea for improvement can submit that idea. And what we've done is set up a review group, which has grown over time to become almost like an improvement brain, like a think tank. Is we've got a group of people made up from people all across the organisation, so corporate, IT, finance, but also multidisciplinary teams and senior management and ourselves, because we made the promise, you know, as someone who's experienced things like DATEX and reporting mechanisms, what's the one thing that really bugs you with those systems is that you don't get any feedback, do you? And so our promise to everyone who submits an idea is that it will be considered in depth by this project review group, and they will get feedback on what happens with it. And we very rarely dismiss an idea, because if someone's taken the time and effort to submit an idea, there is usually some merit in it. And so the outcomes for those ideas are, some of them we'll take on as a team. Often it's that broken aspect, that there is more support in the organisation than people realise, and they just don't know how to access it. And so we'll pass on those ideas. Or it might be that actually this is such a good idea, this is something that senior management might want to consider and incorporate into future plans, whatever. But every idea gets heard. I'm not saying every idea gets done. That would be too much to promise, but every idea is considered. And those staff, we give them feedback, and often it's about us supporting them to implement it. And so we get all sorts of ideas, from the ridiculous to the sublime. You know, we've had ideas that range from, you know, can we have a bin here, to why don't we put a water wheel in the river that runs behind the Royal Glam Hospital and use it to power the hospital. Which, you know, you think, well, how on earth can we do that? But it's not such a stupid idea. It's possible. And in fact, as a hospital, we've just bought a farm, and we're putting solar panels on the farm to power the hospital. So you know, all these ideas are good. And so there's some examples. So Chris Bevan's idea was around putting a bus stop on his Alzheimer's ward, so an older people's ward. And we know that older people with Alzheimer's can get quite agitated, and so sitting in a familiar space. And so his idea was around installing a fake bus stop on the ward, which I know I've seen other places do, but Chris just didn't know where to go to get it done. What permissions did he need? How would he get the material? How do you apply for a business case to do that? And so we were able to help him do that. And so he's now got a lovely bus stop on his ward. I think the second one was around funding for activities it was a supported recovery unit, so the clients in there were bored, and so this was a way that someone had the idea about giving them pocket money, essentially, and so that they could save up some pocket money and use it for activities. And then Kath's idea was around there's lots of benches lying around in courtyards, and the courtyards have been locked up. So can we recycle those benches and put them elsewhere in the hospital? So not a lot of these ideas aren't rocket science. It just takes someone with a bit of spark and enthusiasm to take them forward. And so, how many ideas have we had now, Rachel? Something like hundreds, if not over 200 ideas, and growing. And that's just the bright ideas. We've also got the ideas relating to specific channels. So this has become a big part of what we do. And then this sort of evolved into our 5-minute improvement. And so we pinched this shamelessly from, I don't know if anyone's on from the Welsh Blood Service, but we pinched it from the Welsh Blood Service. And this is a sort of combination of a few things. But underpinning it is lean methodology and process improvement. But this is linked to Simply Do, as in every staff member has got potential to change something around them. What's that one small change that that you can make that might improve your environment and your way of working and your daily life? And so often it's things like moving a printer from here to there, or just tidying up that cupboard, or if we had a better system for how we stored the dressings on wards. And interestingly, this goes down really well with the student nurses, and the nurse we've got in the team who runs this is super passionate about it, because she's got a massive focus on staff well-being, and the way we've marketed this is a way for staff to realise they've got more agency than they know to change their environment around them. And so small changes can make a big difference, and they can, it might not sound a big thing that if you tidy up the dressings cupboard and introduce a better ordering system, but actually that can save someone hours in a week. And so there's a focus on reducing time, saving time, and improving well-being, those pebbles in your shoes. So we're trying to roll this out across the whole organisation. It's also, as one of our teams said, it acts as a bit of a gateway drug to quality improvement, because the way we roll this out to a ward is we give them a very basic course in things like Tim Woods, for those who are familiar with lean methodology, so and process mapping and things like this. So it's a very brief sort of introduction to some basic improvement methods, but we're then giving them permission and working with their managers so they know that they've got the permission to do these in practice. And often people don't realise they got the permission, and then they get hooked on QI and hopefully can move on to bigger things. So 5-minute improvement. It was great. And so again, some ideas. So what was the first one? Chelsea's idea, I think that's just an example of a before, well, that's the after, was a tidied up storage stroke kitchen area, and you can see how tidy it's looking. Having seen some of these areas, I imagine it was a nightmare beforehand, was it, Rach? A paperwork one, chilling without the paperwork. So that was some of the paperwork to do with, I think, checking the temperatures of fridges or something like that, was a nightmare. So they spent, it wasn't 5 minutes, but an hour or so just refining how they did the paperwork and putting a few poly pockets up, etc., and just making it a much easier process. And then the last one was using a bit of IT to auto-generate CPD certificates for staff on, I think it was a surgical ward, was it? ED. And so again, none of these ideas are rocket science, but lots of small ideas, but also that general sense that people are getting that they can improve things themselves. And so you'll have sensed that a big part of what we're doing is trying to improve that community that exists. And so actually, no, sorry, this is the slide about training. Sorry, I've jumped ahead of myself. So capacity and capability. So this is fairly straightforward. I'm sure most of you are offering something along the lines of this, but we've tried to develop what was quite an ad hoc offer into something that's much more structured. And so we've got various levels of training, from the 5-minute improvement to the sort of 1-day improvement course, the 2-day improvement practitioner courses with projects. We're bringing in the QI coach, and we don't offer at the moment, but we support our teams who might want to go on and do some more advanced QI qualifications. And then we're developing much more bespoke offers as well. So we've just brought in things around Lean, 5S, data and measurement. Helen, if she's still on the call, is she didn't actually say it, she's a bit of a whiz in expert, in fact, in human factors. And so we've developed an offer around that, and also looking at how we develop the senior executive board development, but I think that capacity capability piece, what we don't do at the moment, and this is one of the things we want to shift to, is do it in a much more systematic way. And so this is sort of like open to teams who are interested, whereas we'd rather develop capacity in the senior teams with a view to them being able to spread it amongst their teams in a much more managed fashion. So that's part of our strategy for the next year. I mentioned collaborative, so using our version, it's not quite the same, but using our version of the breakthrough series model, we've run a number of collaboratives around pressure damage, falls, and this year we've grown it to include falls and pressure damage, and probably deconditioning as well. You know, for those who aren't familiar with the method, it's on the right there, but essentially it's bringing teams together on a regular basis, supporting them with QI methodology, helping them with data, and hopefully shifting the dots on some of these big safety issues. And we did have some success with the Adult Falls Mental Health Collaborative, so we got a paper published in the BMJ, and Andrea, it's a nice moment for me when I saw this appear in your evidence summary. So a plug for Andrea's evidence summary if no one hasn't signed up to it, because it's fantastic. But yeah, it was nice to see this in there. And so again, making sure that what we're doing is evidence based. This is one of the things we're working on is we had a ward accreditation process, but it was fairly assurance based. And so we've helped them and worked with them to make it much more around QI, and how can, when we're doing ward accreditation, how can we make sure that we're offering people the support to improve the areas that are identified in that process, and so supporting the wards with QI through 5-minute improvement, through ward accreditation, and through training is a big part of what we're doing. And yeah, this was what I was referring to earlier. Is a big part of our work is that network approach. So how can we create a network of people across the organisation? And so we formed our improvement community of practice, and so that brings together people from all over the organisation. The people who are involved in that are people we've spotted, as in people who've been on the courses, people who've got an aptitude for improvement, people who are enthusiastic about it, and we've got everything from, you know, senior, almost exec level managers to sort of band 3 healthcare support workers. You know, it's a collective, and it's great. And this is where the future is for us, is through not us doing the improvement. We're a tiny team in a big organisation, but how can we really harness the power of everyone in the organisation? And the first thing that we're focusing on as a collective is what I've termed the sludge, but it's that bureaucracy that stops us doing our work. It's the things that get in the way of doing a good job. You know, I'm sure I'm preaching to the converted here, but there's too much paperwork and bureaucracy that gets in the way of doing a good job. So how can we work together across the organisation to reduce that? And for example, we looked at the process for audits around wards and falls, and managed to strip away, I can't remember the number of questions, but we stripped out questions from those audits that were duplicated, and I think we cut out 113 questions from the amount of that nurses were being asked to do on the ward. So you can imagine how much time that saved people by taking away 113 questions they would have to do every month on an audit. And that's just a tiny example of the sort of things that we're looking at, but a big focus on that. Not easy, because there's a big culture of assurance. I mentioned the support, so I won't go over that again. And then this is where we want to head to. And you know, this is where if anyone's got any experience or ideas, please contact me afterwards, because we welcome the help. But how do we move to a more systems-based approach? Now in Wales, there is currently a national programme around implementing quality management systems in CTM, so we're working with them on that. It's quite a traditional model, and it might well be the right model, but you know, we're exploring different approaches to how we might take it as well. But essentially it's about how do we embed systems, practices and behaviours in all areas of the trust that support quality improvement. And so that's where we're moving to, and that's how we're hoping through, at the moment, still focusing on that culture piece and the community piece, but eventually moving to that systems-based approach. And so where we are now, well, we did, that's the news report of when we moved out of special measures. I'm not saying it was down to us, but it's part of that whole culture piece across the organisation around moving to a more improvement mindset. And the team has grown a little bit, but we're maintaining the faculty model. We're moving to that systems-based approach, and I think it's onwards and upwards really in terms of how we're doing things. And that's that really. So it's always weird doing this presentation because I'm sort of talking into the void a bit. But I hope that was useful. And we've got 5 minutes or so left, so I'm happy to take any comments or questions. But there's the team. We're in the board game cafe in Cardiff. So as you can see, it's a relatively small team, and some of those people are part time. But as you can see from the smiles, it's a happy team. And I think the reason we're so passionate about this job is that all of us come from within the service, and we're all passionate about improving the well-being and for the staff, and the care that the patients receive. And so that's what motivates us, and that's, I think, what CTM is successful in doing. So that's probably it from me. Happy to take any questions or comments or ideas or tips or whatever. I will do at the end, yeah.
Can I ask you a question, Paul?
Yeah.
Just around patients and carers, because we've talked a lot here about staff and colleagues and how you involve them in the fantastic work that you're doing.
Yeah.
Are they involved as part of your team, or how do you involve them in projects? And have you got any tips in that space?
Okay, so I would say we're getting better at that, but we're not great at it either. And I think that's one of the things that is right up there on our list to do. So for example, in our falls and pressure damage collaborative, we've got a service user, stroke patient, however you want to identify them, on our faculty for the falls collaborative. So, and we involve her in designing the events, and she comes along to speak and engage with the staff who are part of that collaborative. So I'd say that's probably a good example. I mentioned that ICTM includes the value-based healthcare team, and they're responsible for a lot of the patient feedback work that happens, and so we work with them. But I'm probably not the best person to answer, because I don't think it's probably, I'll be honest, I think it's an area we need to develop more of ourselves. We do it informally and ad hoc, but I don't think we're systematic with it enough. And what we've learned from the Falls Collaborative is about having that patient involved has been fantastic. She's really helped us to understand, and we have explored whether we could use Simply Do with patients. It's just not possible at the moment because we've got our own systems, but we do use the data that comes through other patient feedback systems to help us. But again, probably not as good. Rach, anything you'd add to that, or that probably sums it up? Yeah. So I think it's a good point, Andrea. I would say it's a C for us on that one at the moment. It's an area we need to develop.
Thank you for that really helpful response. I can see there's a comment or a question in the chat box, isn't there, from Claire? Can you see that one?
Yeah.
Around the software that you've used and how often the think tank meets up.
So the think tank meets up once a month, and it, like I say, we try and get everyone in the room because I think that's much better. But obviously, it's a hybrid meeting of teams. How easy? Well, one of the reasons we got it is it was working with an organisation that seems to be as passionate as us about using this software, and so it's very easy is the answer. I wouldn't say it was easy to buy it, to get the funding for it, to continue the funding for it. Anyone who's ever navigated procurement will know what I'm talking about. But the actual software itself is, and particularly with the support of the organisation, is easy. So we can manipulate it, we can manage. I mean, I could try and show you, but it'd probably mess up the whole thing. But Claire, if you want to drop us a line afterwards, Me or Rach, I'm sure, would be happy just to give you a few screenshots and show you how it works. In terms of the practicalities of it, you purchase a license, and then you know, and it's all done on the web, so it's not like a piece of software that you got to think. That the most difficult bit we had was we wanted to make it as easy for people to use as possible. So we wanted that when people logged in through their computer, they automatically logged into Simply Do. It's called single user sign-on or something like that. So that technical issue. So my advice would be get IT involved from the beginning. But we've had no problems with it really. It's a dream to use, I think. I keep saying they should pay me to sell it to them because we've sold it. We've sort of, quite a few organisations have used it on the back of us using it, and to be fair, they do give us some free vouchers to give away as prizes. But
certainly be in touch. Thank you.
Yeah, no problem. Drop me a line, and yeah, Andrew. I'm just looking at the chat now. Andrea's put her evidence-based thing in.
Yeah.
So Laura said, "How do you reach all the staff to generate ideas?" That's really challenging, Laura. It's, you know, obviously it's amazing how difficult it is for an organisation like this to reach its staff, is what we found. So obviously we include it in things like the staff newsletter, and what we find is that, you know, not everyone reads a staff newsletter. Lots of people don't even use a computer and work. They've never logged in to a computer. So we do it through staff events. We try and go through team events. We hand out cards on the wards. It's a whole sort of panoply of effort. We've set the system up so you can log in from your phone if you want to, and so you'll see there's QR codes on the back of my photo. We share QR codes. So it's a whole. I'd say I'm still surprised by when we say to people, "Have you heard of Simply Do?" People say no. So I think, how on earth have we not got through to you? So we're still working on that. So that's probably the hardest bit. The software itself isn't difficult. The hardest bit is getting through to people. But also, I think it's hearts and minds. We've noticed a real upshift in submissions in the last 6 months, and I think it's because it's like almost like a positive feedback loop. People are hearing from people that, you know, when you do the staff survey, you never hear anything again, or you do a Datex. When people submit to us, they get the feedback, they get that positive reinforcement, and so that creates enthusiasm. And I think that the upstick we've seen in the last 6 months is as a result of that that positive sort of feedback that people are giving. And we've got some nurses on the team, and nurses just boss everyone around into doing it as well. Okay, so looking at the questions. Anita, starting a podcast area. We're starting a podcast series. I'm going to pinch this for pride, this idea. Well, funny enough, Anita, I do a podcast as well. It's called The Oral Apothecary. Please check it out. And one of the things we ask our guests is what's a song or a career anthem that, and again, these are all gimmicks, but they encourage people to engage. They encourage people to tell stories. If I said to you, what's a song that you relate to work, there's a story behind that song that suddenly engages you and makes us part of our community.
Great minds think alike.
There we go. Yeah.
He
needs no encouragement, Anita.
It's come up as part of 100 Voices as well, actually. A lot of people have shared a song which kind of drives them forward. So
there we go. There's my self-promotion in the chat. So.
Fantastic. So it feels like we are at a close, and I just wanted to say thank you so much to you both for that fantastic presentation. It was extremely insightful, and I'm 100% sure that everyone on the call has taken ideas away from it. I do have to, before everyone shoots off, just have a plug for Anita's session tomorrow. So Anita and her team will be sharing their own spotlight tomorrow morning. So please do sign up for it and attend. That it's all part of the DigiBook, and it's not too late to join in QIB activity. So do join in with that. Anything else you'd like to say, Anita, given the fact you're in charge of this wonderful week?
I'm just going to say, check out our socials tomorrow when we will be releasing our first podcast from the Academy. So check it out. It should be on LinkedIn.
And I put my email in. Anyone wants to contact me, then please get in touch. And thank you to you both and everyone who's been involved, because I think QI Week's a great idea, and it's great to see how it's growing as well. So you're doing your bit. You know, we're talking about networks in CTM, but I think networks across the country as well is the thing.
Absolutely. So thank you all very, very much indeed for your time, and I'm going to stop recording. If you wish to carry on and chat, all the better, but I will stop the recording. Thanks so much.